Bismillahirrahmanirrahim. I'm going to start with this verse from Surah Baqarah 32. They said, "Glory to you, we have no knowledge except what you taught us. You are all knowing and all wise." Bismillahirrahmanirrahim. So, my name is Dr. Hassan Saleem. I'm currently working as a cardiovascular and cross sectional radiologist at IDC. We've been doing cardiac MR since 2016, along with the collaboration with a cardiologist who is a good friend from Virginia Tech, who was formerly trained in cardiac imaging. So we are spreading the cardiac imaging across Punjab so far, and the services Rawalpindi, Lahore, Faisalabad, and Ahmedabad, they are different areas. So I'm just going to be very quick because it's a very large topic, as you know, and we run around 2 hours workshop back to back to cover the entire spectrum. So I think it'll be very difficult for me to cover the entire spectrum, but I'll try to be very precise. I'll start with the normal cardiac MR. Here you can see the white blood images. These are cine images, and we try multiple acquisitions. So the basic idea is to look at the kinesis and the contractility of the heart and the nice movement of the valve. You can see in profile in different views. This is 2-chamber, this is 4-chamber, 3-chamber view, and the LVOT coronal image. This is followed by the stack images. This is performed for the functional assessment for your EDs and ES and stroke volume and all those parameters that you want. We do different methods to do that, and that's kind of now become gold standard there for the evaluation of ejection fractions of the LV as well as the RV. Then we do black blood imaging, in which we are doing inversion recovery. I'm not going to go into the physics of this, it's quite boring, but we are taking away the signal that is coming from the blood itself so that you can have a good morphology of the wall itself. So this is primarily done for edema imaging in patients with MI, myocarditis, and so on and so forth. So you can again say, you can acquire different planes. These are 4-chamber views, and this is again short axis view, T2 without fat suppression. Then you can perform your perfusion scan either in resting or in stress phase. Usually in Pakistan we do adenosine, 140 mics per kg is the similar rate. We give it over the period of 3 minutes. In the last 1 minute, we do the perfusion scan. And you can see the blood coming in into the right side, then to the left side, and then disseminating into the myocardium. Then we do nulling of the myocardium. Again, it's a physics, but the normal LGE for you is a black one. So it should not be enhancing anywhere. Sometimes the contrast is retained within the fibrotic or the infarcted tissue. So that is very much clear in the background when the normal myocardium is all jet black. So this is a very basic slide for the evaluation of LG images, late gadolinium images, to differentiate between ischemia and non-ischemic cardiomyopathies. In the ischemia, you can see the subendocardial involvement. The white part is the abnormal infarcted tissue, the scar tissue, and you can have the transmural involvement. It has to be within some arterial territory. And then the non-ischemic cardiomyopathies are variable in position, mostly mid-wall, subepicardial, or could be global. That will help you narrow down your differential diagnosis. This is a very novel T1 mapping. It is done without contrast, so primarily done for the infiltrative disease processes. You can differentiate on the basis of T1 mapping. The more the higher values, the more the infiltrative process there is, including amyloid, chronic MI, acute myocarditis, and then slightly higher in the HCM patients, whereas in the fat and iron it's going to be low. We can do pericardial tagging. That's done for primarily for constrictive pathologies. Here you can see in the diastolic phase, the strips and the grids that are applied are breaking up in the diastolic phase because the heart is expanding normally. I'll show you the case of constrictive as well. We do get a lot of patients of thalassemia. It's quite prevalent in Pakistan, so iron quantification can be done very easily. It's in the guidelines, you have to do cardiac MR for iron quantification after every 10 years after the 10 years of the disease. But unfortunately, there are no guidelines in Pakistan available right now. So we also do simultaneously the liver imaging as well. So that's very easy, just 20 seconds, single slice, and you can get a very good information from there. So coming to the library, you can evaluate patients with dilated cardiomyopathy. You can see now the difference between a normal and abnormal myocardium. You can see the very feeble looking heart, very slow moving heart, and the ejection fraction is really down around 15%. And this is again another case. You can see the blood literally swirling within the dilated chambers, and the heart is hardly contracting. It's around 12 to 13% ejection fraction. We do get a lot of patients with viability, obviously. And in this patient, you can appreciate the thin interior wall in this two-chamber view and the apex. And look at the contractility pattern. It's very easy to observe here. You can see how the inferior wall is contracting, whereas the interior wall and the apex is kind of, very slow moving, kind of akinetic. On LG, you get information. You confirm your findings. The infarct is there. You can see that it is fixed to a territory. It is subendocardial in the septum, whereas it is kind of transmural in the apical region. Similar patient that we were looking at the cine images. The interior wall, as you can see, is infarcted. There is some black strip, if you can appreciate on this image. This is a normal myocardium that is spared. So this is a kind of a viable myocardium there, but apex is non-viable. Depending upon the thickness, you can easily measure. It's very reproducible, not a very big problem. Obviously, thrombus is also one of the major indications. This is a young patient from Lahore in Evercare Hospital, presented with big thrombus there, saddling thrombus sitting at the aorta. And on echocardiogram, there was a mass-like area mobile within the LV, and they wanted to see whether it's a mass or is a thrombus. So we perform EGE images on a high TI values, and usually the thrombus is non-enhancing as compared to the masses, which are usually enhancing. Also, you can do LGE, and in the similar patient, you can see some patchy areas of subendocardial LGE there. So the primary diagnosis of the thromboembolic phenomena was made. There's another case here. You can see a large fluttering thrombus there, about to get dislodged into a systemic circulation. And there's a large apical and LAD territory infarct in the apex. You can see non-enhancing thrombus there. And that's the aorta where it is, kind of on the edge. Another case, no MI, nothing. Patient had an autoimmune disorder, young female. We found out a small thrombus there. And on LG images, again, it was non-enhancing. Patient was non-compliant, stopped taking drugs, and we followed this patient up, presented with left MCA territory infarct. So here you can see on MRA, the left MCA is gone. We do get, obviously, a lot of HCM patients. Here you can see how nicely you can reproduce the SAM images. You can appreciate the obstruction there. There's on the LVOT and the jet, which is going into the left atrium. So this is SAM on cardiac MR on three-chamber view. You can also do, obviously, black bladder imaging. On post-contrast, obviously, it's very important for you to appreciate the LG, because that really depends on the prognosis of this patient. You can see multifocal, these white patchy areas in the epicardial as well as the mid myocardium as well. And the pathognomic sign is that there is usually enhancement at the RV insertion site. Another patient, another variant, mid-cavity HCM, you can see how the mid-cavity is thickened, obliterating the LV. There is a small, very small mass-like area there, and you can see the apex is not moving very nicely. So on EGE, early gadolinium images, you can see a very small thrombus sitting there at the apex, and on LG images on 4-chamber and 2-chamber view, there's a scar which is involving the apex. That's primarily because of the dynamics. Then asymmetric HCM, that's a straightforward diagnosis on MR. Anderson-Fabry disease, a young guy, I think it was a child around 10 years age, presented with a very thick myocardium. There was no LG. Then again, T1 mapping helps you. the T1 mapping value was on the lower side, and that helps differentiate between HCM and Anderson-Fabry. That's one of my early cases. I think it was in 2017. Patient had a sarcoid, known sarcoid, went to a medical specialist with arrhythmias, and he suspected sarcoid. And luckily sent this patient for a cardiac MR, and there was a scar, epicardial scar there in the septum, and straightforward sarcoid, cardiac sarcoid diagnosis was made. Later on, patient had CT at our center. There were large lymph nodes, some of them calcified, and the device was placed. Then myocarditis. There's a young fellow, again, an unfortunate patient, had to flew all the way from Karachi, had a big patches of the COVID myocarditis, still observable on the imaging. And it was a young family traveling with small kids. Imagine the whole myocardium is almost scarred. The AF was really down. I think it was around 15% or so. And while I was doing my workshop in Germany, they had like 45% of the patients who were undergoing cardiac MR during COVID with shortness of breath, with low EF, were actually positive on cardiac MR. Amyloid is again a very straightforward case on cardiac MR. You can see some septal thickening, apical sparing, biatrial, biventricular enlargement, and you can see some pericardial effusion is there. EF is really down. So this is for a reference, a normal look locker series, you can say T1 Scout, where you can see the myocardium is getting black somewhere in the middle images. And that is the true value of the myocardium, which we put in our console, in our scanner, to run the LG images. Whereas in the amyloid, usually my technologist will run to me and say that I cannot null the myocardium because of the protein in amyloid. It just absorbs up all the contrast and very difficult to get washed out. You can see how much enhancement is there. Everything is enhancing. That's a pretty straightforward case of amyloid. A very unusual case, again, amyloid with a very small thrombus, non-enhancing thrombus sitting in right atrial appendage. I'll be a little quick. Constrictive pericarditis, you can see a thick frond of pericardium and this constricted heart. It is very easy, again, on cardiac MR. You can see that thick frond of thickened pericardium on LG images. You can see that extensive enhancement in the parietal and visceral layer. And like we discussed before, the pericardial tagging image. Here you can see this is for a reference, a normal image. And this is a patient with constrictive. Here you can see the stripes are not breaking up because the heart is not expanding at all. You can also appreciate the septal bounce there. It is nicely, it can be nicely seen on cardiac MR. Here's a case of post-MI acute pericarditis. Had an MI, there's an enhancement in the inferior wall. Patient was done PCI, and patient still had complaints of chest pain, and it was actually acute pericarditis. The entire pericardium is enhancing. We do get a lot of patients with massive. This is my first patient in 2016. I think middle age, around 50s. Her age was in 50s, and she had a mass on echocardiogram. There was an enhancing mass in the inferior lateral wall. Salman called me up and he said, listen, I think it's kind of a secondary tumor. Doesn't look like primary. You have to look at other images as well. So we found out large nodal masses in the axilla. The biopsy was suggested, turned out to be Hodgkin lymphoma. And these are the patients who actually benefit from these imaging. And I'm still following this patient up. It's been, I don't know, 7, 8 years. And that mass calcified after the chemotherapy, and she's still living. Alhamdulillah. Cardiac lymphoma. Here, there's a new case. Here you can see large mass in the AV groove bilaterally. The vessels are even encased by this mass. This is RCA. And if you can appreciate, there's small flow in the left circumflex as well. So on post-contrast images, enhancing mass, literally engulfing the entire heart. Rhabdomyoma, there was a case of tuberous sclerosis presented with rhabdomyoma. There's again unfortunate patient, was young, had a big mass, fungating mass, and there was also a secondary in the RA. I don't have any histopath of this patient. This patient expired on the table while doing biopsy. There's another patient, very favorite for our, at least radiologist perspective. You can see multiple cystic areas within the myocardium. That's hydatid cyst. And that's very unfortunate, very difficult to treat. That's peripheral enhancement there. ARVC, that's a family of three. One sibling died of ARVC, two of them came for the imaging. Here you can see dilated RV and RA. You can also see some fatty infiltration in this patient, which is not the part of the criteria anymore. And you can see enhancement in both ventricles. So this is biventricular dysplasia. Last few slides, structural diseases. Patient actually came for the evaluation of ARVC. Turned out he had a big ASD, which was there. Then Epstein anomaly looks like this. Atrialization of the right ventricle. You can see the large atrium, and these are the flaps of the tricuspid valve. You can do valvular diseases. It's very easy. That's another topic. It's a big topic there. You can also evaluate the precise measurements, and it's very easy to quantify them. Thank you all. Jazakallah.